Hi, may I have your attention, please? Thank you. Very good. Okay, we're going to start our program now. I think we have a very great program for you today, very informative. And thank you all again for being cooperative. We have over 200 people here today, and I know it's squeezing 10 at a table, but we needed to make it happen. So before I start about today's program, I'd like to mention that a topic that has been coming up before all our small cities in the county for quite a while now is coming to the fore. That is the prospect of a new jail. So there are two programs in the next month that I want to tell you about. One is 2 weeks from today. It's the League of Women Voters. They're beginning a community conversation on incarceration at their meeting June 10th at the Mount Baker Theater's Encore Room at 7 p.m. There'll be a talk on the ACLU's campaign to end mass incarceration. Then 2 weeks following that, 4 weeks from today, right here, June 24th, City Club will present a panel discussion about what's happening on alternatives to incarceration nationally, and also jail financing and what Whatcom County is doing now and hopes to do in the future to reduce jail populations. So that's coming up in the next month. Now today, our topic is the Affordable Care Act, Promise and Practice. The Affordable Care Act had a terrible birthing process with over 161 amendments before it even got passed, and challenges all the way to the Supreme Court since then. One that was ruled in favor of Obamacare in 2012, and there's another one before the Supreme Court right now. So today, we're going to be looking at what has happened in the 5 years since March 23rd, 2010, since the law was signed, and what are some prospects for the future of healthcare in Whatcom County, healthcare in Washington State, and healthcare throughout the country. We have three speakers today who are going to speak each in turn, and then we're going to have a time for questions and interaction among panel members. So here we go. Our first speaker is going to be Aaron Katz. He's a principal lecturer of health services, global health, and law at the University of Washington School of Public Health, where he teaches several graduate courses in health policy. He also has an adjunct appointment at the University of Queensland in Australia at their School of Population Health. His Bachelor of Science degree is from the University of Wisconsin in Madison in 1974, and in 1975 he received a Certificate in Public Health, master's degree equivalent, from the University of Toronto. He has held numerous academic leadership positions, including his current role as faculty coordinator of the Health Systems and Policy Concentration of the Health Services Program, that's Master of Public Health, and is founding director of the Leadership, Policy, and Management track of the Global Health Master of Public Health Program. Impressive titles. Aaron received the American Public Health Association's Award for Excellence in November 2006, and the Outstanding Teaching Award from the UW School of Public Health in 2004. And at the 2011 State of Reform Washington Health Policy Conference, he received the Health Reform Leadership Award. He has developed a deep understanding of the U.S. healthcare system and its strengths and weaknesses during a career that has spanned more than 30 years and has 3 bouts of healthcare reform. He has worked in health policy and planning in Washington State since 1978, serving as a health planner, policy and planning consultant, lobbyist, and political advisor. Please welcome Aaron Katz to City Club as he shares his perspective on how the Affordable Care Act is being implemented throughout the nation.
Thanks. Thank you, Don. Thank you for inviting me for this forum. This is obviously a very important topic for all of us. So I'm going to try to give you very briefly a sense sort of nationally about what's been going on around, and perhaps because of the Affordable Care Act. We were talking a little bit before the session, and I think it was Sue asked me, am I cynical? And what was that? Of course the answer is yes, but cynicism is just, the other side of hope, I think, the other side of the coin of hope. So you'll hear a bit of both from me. So let's start off with the positive, the good news. Since the Affordable Care Act was enacted and the coverage expansions began in 2013, 17 million more Americans have insurance than before the law. That's $17 million in a population, I don't know, what are we, 310 million now? It doesn't sound that huge, but it is by far the largest increase in the insured population, certainly since Medicare and Medicaid. So that's a big change, and that's a net change. If you look across all adults, there are about 13% of adults in this country who are uninsured, and that's down from 18% as recently as mid-2013. So something's been going on to get people insured and to reduce the number of people who are uninsured. Now, one of the big changes in the Affordable Care Act was the possibility of states expanding the Medicaid program. And if any of you heard me in the lead up to the Affordable Care Act and soon after its enactment, you would have heard me say that the Medicaid expansion is the only evidence-based provision of the Affordable Care Act. And I meant that. I still think it's true. That is, we knew that if we expanded eligibility for Medicaid, more people would get covered under Medicaid. We had decades of experience in that, and that's in fact what happened. 29 states have expanded Medicaid, and we've seen a 25% increase in the number of people covered nationally by Medicaid. Even in states that did not expand Medicaid, we're not going to go into the Supreme Court stuff, but there are states that have not expanded. Even in those states, Medicaid expanded by 8%. Okay? And the reason is basically that there's been so much PR and talking about Medicaid expansion that people who had been eligible but had not enrolled said, oh, that might be good for me, so they enrolled. Now, Medicaid expansion is not just important because people with Medicaid have an insurance card, so they have money behind them when they go to the doctor or the hospital. That's, of course, very important. But there's recent research that shows that having Medicaid coverage is related, particularly for parents, having Medicaid coverage is related to upward economic mobility of their kids. Okay? Again, this is sort of intuitive. If you think of insurance of any type as financial protection, which allows a family to invest in other things like, say, education, then it makes sense. But there's actually been recent research to show that. Another provision of the law are these marketplaces, what we call in this state the health benefit exchange. 11 million people have been enrolled nationally in state-based and the federal exchange. And I have to admit, I call these marketplaces an experiment. 11 million people is a pretty good outcome for an experiment. So that seems to have been working. And we've even seen about 8 million more people covered in through employer coverage nationally. So that seems all to the good. And one of the goals of the Affordable Care Act was sort of to create a culture of insurance, that we should all have insurance, right? And that hasn't sort of been the culture in the U.S. And we seem to be moving in that direction, that there's growing expectation that all of us will be covered. Okay, what about costs? That was another goal of the Affordable Care Act. Since 2012, spending on health care per person has grown at about 3% a year. Now, that's a lot lower than it was 8 or 10 years ago when it was growing at 2 or 3 times that, 6, 8, 12% a year. So costs have come down, and as Commissioner Kreidler will probably talk about, the premiums that he's been approving in the marketplaces have been much lower, actually nationally, with some exceptions, than anybody expected. And if you dredge back in your memory, you probably will dig up the reports we saw in the paper, both here and elsewhere in the country before the Affordable Care Act, of individual policies going up 25, 35, 50% a year. Okay? So, you know, that seems to be a better situation. And then the quality and outcomes thing. So another kind of cluster of goals in the Affordable Care Act was actually to improve how how health care is provided and the outcomes of that care, and actually improve health. And I would say that one good thing in terms of the impact of the Affordable Care Act is that there's a lot more discussion about the health of communities and about the outcomes of care. There are provisions in the law about the requirement that hospitals provide community benefits. And we've seen governments, both at the federal level, primarily through Medicare, and at the state level, in many cases through Medicaid, of leading the effort to redesign the healthcare system so that it serves people better. Provides the right care at the right time for people when they need it. So those are all, I think, things that we can look at and say, geez, maybe the Affordable Care Act is doing some of the good things that it talked about. Now let me talk to you, tell you about sort of the other news. We've had a long experience with coverage expansions. Okay, going back again to Medicare and Medicaid in 1965, we've seen expansions come and we've seen expansions go. And we know that if we can't control healthcare costs, at some point the governments, federal and state, will have to retrench on these expansions. We know that that's the case. We have ample evidence of that. And the other thing that we know is that coverage is not enough, that making sure people have the care they need is really what's important. And I would say we're at the initial stages of maybe understanding whether care is going to improve. Now, on the cost side, I said that costs have been going up per person about 3% in the last few years. Well, in fact, costs had been very low since the Great Recession. They've been running at about 2 to 3% increases since 2007. So it's not totally clear that the Affordable Care Act is a main ingredient in holding those costs down. The other thing that we've been seeing happen is consolidations of healthcare systems. We've certainly seen it in this state, up and down the I-5 corridor, and like in the past, proponents of these consolidations have argued that the resulting bigger organization is going to be more efficient, more able to invest in things like health information technology, and in fact will help to make the system more efficient. But the research suggests otherwise. The research on consolidations of hospitals shows that when hospitals combine and become bigger, prices go up. And again, it's understandable. They're bigger. They can negotiate from a much stronger stance with insurance companies. So I think this is one of the areas that may be related to the Affordable Care Act that we need to keep our eye on. And finally, in the cost arena, affordability. Yes, premiums are lower than we expected in the exchange, but another thing that's been happening in the exchange and outside the exchange is the rapid growth of high deductible plans. That is, plans that have relatively low premiums, but when you actually need care, you pay through the roof. And the problem, one of the challenges is in the marketplaces especially, all these people who have gotten enrolled, many of them have never or have had little contact with the healthcare system and the health insurance system. And if any of you looked at your health insurance policy, whether it's Medicare or a private policy, it is like impossible to understand these terms. So what's a copayment? What's a deductible? What's coinsurance, et cetera? So when there's price shopping going on, largely it's around premium. Well, high deductible plans are cheap on the premium side. There's been recent research to show nationally that 50% of households that are non-poor and they're not headed by an older adult have liquid assets. Only 50% have liquid assets to cover the deductibles in their plans. So 50% of non-poor households have adequate assets, liquid assets to cover their plans. If you look at poor households, households below about 2.5 times the poverty level, that drops to 20%. So 80% of poor households that have high deductible plans, and that's many on the exchange, probably don't have enough money to cover the costs that the amount of money they would have to put out for care. And then on the outcome side, well, you know, really, if we want to improve health, is the medical care system the best tool? What we know about health is that it's largely a product of income, education, housing, food security, and those sorts of things. And as much as, you know, I love my colleagues in the hospitals and in medical clinics, et cetera, they're not trained to improve the health of populations. They're trained to fix us when we're sick or injured. Now, it's a very expensive system, right? Where are we at? $3 trillion a year now, nationally? Or maybe it's only $2.5 trillion, I don't remember. That's a lot of money. So obviously, the Affordable Care Act is going where the money is to try to fix the problem of health or improve our health. But I really wonder whether I'm pretty sure it's not the right tool. So we can talk about the accountable communities of health. You've got one growing here, and whether it will be able to leverage the medical care system to improve community health, but I have my great doubts. And the final thing I'll say, just to give us pause, of course, is that we have this, what I call the incessant assassination environment. The repeated attacks on the Affordable Care Act from all corners, in all ways, bureaucratically, regulatorily, and of course legally with the challenges that have reached and will reach the Supreme Court. And that creates a very difficult environment to implement a very, very complicated law. Just to give us perspective before I close here, Medicare and Medicaid were enacted in 1965. Who can tell me how many years it took for all 50 states to have a Medicaid program? 1, 2, 4? 50, no. Arizona was the last one in 1982, so it took 27 years. So just to say we all should take a deep breath about all these states that haven't expanded yet, they will, if the law continues as it is, they will eventually. But these are very complicated laws to implement. If you read the paper, there are all kinds of glitches in the law, problems, probably as a result of the quick writing or all these amendments, Don, you mentioned that were passed in the dead of night or whenever they were passed in the law. These are all problems that in a normal political environment, Congress would go about solving. Congress would go about solving, seriously. But that's if we can get back at some point to a functional political environment, all of these problems in the Affordable Care Act are solvable. That's not to say the Affordable Care Act can reach its goals if the problems are solved, but the problems in implementation, in income eligibility, bureaucratic and administrative challenges, those can all be solved if we can change our politics. So that really comes back to, all of our efforts in the political system to change the American politics. I noticed some guy out here collecting signatures to overturn Citizens United. So there's an example of one strategy that I think eventually will help put us back on a plane that would allow us to improve the Affordable Care Act so that it can reach at least some of its goals. Thank you.
Thank you, Aaron. Our next speaker is Insurance Commissioner Mike Kreidler. He's Washington's 8th Insurance Commissioner, first elected in the year 2000. He's now serving his 4th term. He earned a reputation as a staunch advocate for consumer advocacy and as a fair and balanced regulator. Before that, he served 16 years in the state legislature, first as a representative, then as a senator. Then he went to Congress, and in 1998 was appointed regional director at the U.S. Department of Health and Human Services Region 10 office in Seattle, where he stayed until the year 2000. And since 2007, Commissioner Kreidler has chaired the National Association of Insurance Commissioners Climate Change and Global Warming Work Group. He led a successful push for insurers to disclose how they are preparing for the potential risks associated with climate change. A doctor of optometry, he practiced at Group Health Cooperative in Olympia for 20 years. He holds a master's degree in public health and retired from the Army Reserves as a lieutenant colonel after 20 years of service. And he's not a stranger to City Club. He was here in August 2012 and June 2010 to speak about healthcare issues. And some of you may remember that he was here in February 2009 as part of his journey around Washington State to initiate discussions about healthcare and the possibility of healthcare reform. So welcome again, Commissioner Michael Kreidler.
I don't know. Are these on?
I think it's on.
Okay.
Thank you very much, Don. Indeed, these are exciting times. I just got back a week before last from Zurich, Switzerland, testifying before a United Nations group on climate change, and I only make mention of that because I represented the U.S. regulators, insurance regulators, on that panel. Well, that there's more to the Office of the Insurance Commissioner than health insurance. I remember, and Aaron did a great job of giving kind of the history and the impact nationally, but I certainly remember when we were coming up in 2009 and 2010, where as we approached the passage of the Affordable Care Act, that there were those out there that were making predictions that we'd see premiums that would be skyrocketing. We were seeing consumers were being told that they'd have fewer options. Insurers would wind up leaving the market because of this dread Obamacare coming into effect, when in fact, as Aaron pointed out, we've seen dramatically different results. And here in the state of Washington, that's particularly true, where we've seen some 380,000 people now that were uninsured now having health insurance, and that doesn't include the expansion of the Medicaid program, which would add another 400,000 people that now have health insurance coverage. One of the interesting statistics for those states that did not expand the Medicaid program, because of adverse selection, you're getting people who would be eligible for the Medicaid program, but in dire physical condition and therefore very expensive, going to the commercial market through their federally facilitated health insurance exchange. And as a result of that, you're seeing much higher rate increases in those states that did not expand Medicaid because of adverse selection, because of the failure to do the expansion, something that we didn't do. And as a result of that, we've wound up being ranked the 4th most successful state in reducing the number of uninsured in the country. And we've seen our rates drop dramatically from 12%, or excuse me, closer to 15% And now we've dropped it down to just over 8%, a dramatic change in the number of people who are insured in the state of Washington. And here in Whatcom County is particularly good news. We were always below the state average at about 14%, but we've seen from our numbers in the Office of the Insurance Commissioner that we're closer to about 5% right now in Whatcom County. No little bit of credit goes to the Whatcom Alliance and their hard work, and people like Sue Sharpe, who sits to my left, for what you've seen accomplished here in this community. Now, one of the things that's really dramatic, and again, it was part of the doom and gloom that carriers would leave the market and we'd have less competition. We have 17 insurers now that have just filed for the 2016 market, and that's 17 insurers. That puts us at the very top from the standpoint of the number of insurers in the country, for the number of insurers. And behind them, there stand on nearly 250 plans that these insurers have put forward. We've also seen 13 of the 17 insurers have filed something like 188 plans just inside the exchange, the rest being outside. Now, one of the areas that we continue to have some problems, and Aaron touched on it, we wound up with about 5.4% in the rates that were just filed for 2016. Now, that's what they wind up filing. That's not what I've approved. We'll be going through those with a fine-tooth comb to make sure that they're justified and sufficient for what they're putting forward policies. But that's still the lowest we've seen in the last 8 years from the standpoint of rate increase. So dramatically, these rates are being suppressed. I think part of it is, too, that we've wound up with carriers being levelized, because now they have to cover in the individual and family and small group market, they have to cover the 10 essential health benefits. You also have limitations on out-of-pocket expenses that you didn't see before. So now competition is starting to shift. And one of those areas that we've seen has been in the area of what we refer to as narrow networks. And that narrow networks innately are not a bad thing, because they can help to hold down health insurance premiums. But again, it's one of those where the average person does not have access to the information, nor are they necessarily astute in being able to do the kind of homework that's necessary to really understand which providers. Because the first question most individuals who are making their own choices are going to ask is my doctor in this plan? If I have a specialist, is my specialist in this plan? Is it my clinic in this plan? Is the doctor, is the hospital that is in our community in the plan? And that information, unfortunately, and Don, you asked me to mention some of the challenges we have still out there, is making that information more readily accessible and transparent to individuals, along with some of the out-of-pocket expenses, the copays and the deductibles, so that when you make a choice, it isn't necessarily what the lowest premium is going to be from one month to another, but it's also understanding the complexities of what out-of-pocket expenses will I be facing, and what do I see in the way of a network going forward of providers. Is it going to be sufficient for my needs? And if you're on pharmaceuticals, you want to make sure that the drugs that are covered as a part of that health plan are going to be the drugs that you need because of medications you're currently on or anticipate. So we're looking at more people, more options, more competition in the market. I mean, it's going in the right direction. But again, we're facing some of these challenges right now of kind of the lack of transparency in the shopping experience. That's really where we're all focused on the health insurance exchange, is to providing that as a platform where you can go in and do that kind of comparison. We have some challenges inside the exchange from the standpoint of the small group market. One of the reasons why I think we're doing very well in this state is because I've taken a very hard line on a couple of the major issues. One of them was that if you have a canceled policy, you can't keep that canceled policy going forward. It would have innately created two risk pools. good risk and bad risk. The bad risk would have been in the fully compliant plan. The good risk would be over then would have stayed because the plans were most likely cheaper, but also there'd be individuals that as long as they weren't sick wouldn't try to get in where they'd have stronger benefits. These kind of two risk pools are innately destabilizing to the market. But in the case of the small, and another one is that we wound up as being the only state in the nation that adopted rules for 2016, or 2015, where we have network adequacy standards by rule. It's interesting if you take a look at the state of California, which in January by emergency order wound up adopting rules for network adequacy. They largely took what we had adopted already here in the state of Washington. The state of New York is in the process of doing it. The federal government's in the process of doing it because they wind up running exchanges in the majority of states. They're also in the process right now of moving toward establishing network adequacy standards. Again, helping to stabilize the market. But in the case of small business, a small group market, we've had our challenges. They have nationally, but ours has probably been somewhat more acute here in the state of Washington. In no small part because of the presence and how they operate of association health plans that can certainly be strong programs that are offered, but we need to make sure that they play by the same rules so you don't have adverse selection. And that's one where I'm concerned, and it's been a disincentive for insurers entering the small group market through the exchange, or shop as it's referred to. We need to make sure that they all play by the same rules. Those rules being ones that to make sure that one, it's a bona fide association that is recognized by the federal government, and the second, obviously, is to make sure that the rates they charge are not discriminatory against their members. If they want to be an insurance company, they have to play by insurance company rules. If you don't have that kind of underlying, you will discourage the entrance into that small group market, and again, limit the choices that are available to small employers. Again, a real challenge, but it's part of what we need to wind up doing if we're going to be successful in holding down healthcare spending. In conclusion, I would just say that Aaron pointed out that we have some challenge right now with the United States Supreme Court. In a matter of a couple weeks, we'll be issuing the decision in King v. Burwell. It has the potential, maybe not so directly, to impact the state of Washington, but the slipstream of what would happen nationally is very likely to catch even states like Washington, which did create its own exchange, and it's through the exchange that the subsidies are being offered. It does not bode well if the Supreme Court goes against the administration. I think there are some ways to work around it, but it'll take a while to work out, and it again adds additional complexity to a system. What we've had to do right now in order to have real competition between insurance companies is to hold a common standard and by virtue of being very aggressive in doing that so that everybody plays by the same rules, we've wound up increasing the number of insurers, more competition in our market, and being able to hold down rates much more successfully than we've seen in other states. So it's really benefited us, but at the same time, going forward, we're going to face additional challenges. If King v. Burwell goes against the administration, it'll add another complexity and challenges for all of us. Again, the health reform here in the state of Washington, and from what I see nationally, it is working. It's working better here than where you see elsewhere. People are getting coverage, and we're certainly seeing more choices out there for consumers. The healthcare reform, well, being one of making a very complex system by virtue of wanting to have competition between commercial insurance or in the commercial market, but among insurers, it is obviously would have been much easier if they'd done something simpler, such as just expand Medicare to the rest of the population. And it would have made the life of one regulator for the state of Washington's life much easier, I can assure you. Thank you once more for having me back.
So you're going to propose that in the next session?
Thank you, Mike. Now we're going to bring it to the local level. Our final speaker is Sue Sharpe, the Executive Director of the Chuckanut Health Foundation, and she's in her 7th year as Executive Director of the foundation, which was formerly known as St. Luke's Foundation. And since 1982, the foundation has invested over $16.5 million to improve individual and community health. Sue has over 35 years of nonprofit and healthcare experience. Her career started at St. Joseph Hospital in 1977, where she served in a variety of healthcare planning and executive positions. In the late 1990s, she started a private consulting practice focused on community-based planning and nonprofit organizational development. She served as the leadership consultant and facilitator for the development of the Whatcom Alliance for Health Advancement from 2002 to 2008. Sue was appointed to the Washington State Health Insurance Partnership Board from 2007 to 2011 and was co-chair of Commissioner Kreidler's Healthcare Reform Realization Committee from 2010 to 2011 in preparation for the launch of the Affordable Care Act in our state. Sue is presently Vice Chair of the Board of Trustees of Western Washington University, her alma mater. She's also a board member of the Whatcom Alliance for Health Advancement and a member and former president of the Bellingham Bay Rotary. Sue has a passion for working with community-based groups that engage diverse stakeholders to promote community health improvements for all, and believes that local communities are best equipped to drive those changes. Today, she'll talk to us specifically about local changes to transform healthcare in Whatcom County. Welcome, Sue.
Well, thank you all. I'm assuming a role here very similar to the role I assume with my family when we're skiing. I'm the sweeper. I'm the last one down the hill. I pick up the mittens, I pick up the hats, and I go slower than anybody else. So I really appreciate this opportunity to chat today and to really be on this panel with both Professor Katz and Commissioner Kreidler. We're at a pivotal point, as you've heard, and as a community, we have a chance to refocus after the Affordable Care Act on the next chapter in our commitment to make health and health care work for everyone in our community. There's a lot to cover on this subject. Fortunately, both of these gentlemen have hit on some of the points I was going to mention, but I am going to skip a little bit. I'm going to skip my stone across the pond here and cover a lot of high points. I want to say that I relied a lot on the input from community partners, many of them in this room, who have worked together to advance the Affordable Care Act and have worked together through implementation. I could list them, but it would take me the rest of the day. But let me just say that their input was thoughtful and it was consistent. They all shared one observation. WAHA, the Whatcom Alliance for Health Advancement, was pivotal in bringing partners together to reach and enroll the uninsured in this county. And that number was 14%, and I think Larry Thompson, who's the executive director of WAHA, would tell you it's probably now in the neighborhood of 3 to 4%. And that is best in class, folks, in the state and in the nation. So we can talk about uninsured rates and insured rates, but what does that mean for the people in Whatcom County? What does it mean to everyday people? Almost all of Whatcom County has health coverage. People are secure in seeking care they need for themselves and families without fear of being denied due to pre-existing conditions or facing financial hardships and, in some cases, bankruptcy. This is the part of the Affordable Care Act that really matters, and one we rarely talk about. But in addition to coverage, this community was talking and working on ways to improve our health system well in advance of the Affordable Care Act. WAHA facilitated a process that literally involved hundreds of community partners and leaders in evaluating and proposing how to improve health care in this community. Transforming health care called for whole health, achieving the triple aim, the issue of access, improving quality, and reducing cost through a number of initiatives: care coordination, patient-centered health homes, behavioral health integration, aligned financial incentives that support the right care and investments in population health, community engagement and accountability, and health information exchange. The analytics required to inform and report what is working and what is not. Because of that pre-work, we as a community were prepared to take full advantage of the opportunities the ACA provided. WAHA convened community partners and attracted needed funding to support local efforts to improve care and reduce cost. We've implemented a community-based intensive case management system for chronic diseases and complex patients. That means that people, whether they're in their physician's office, in the emergency department, being discharged from the hospital, or the jail system, or homeless, are receiving the support services they need. We have advanced the implementation of patient-centered health homes. Interfaith Family Health Center, I saw Dea Scooby in the room, is out in front on this effort. And we have a community commitment to end-of-life care, where patients, families, and caregivers can approach this very difficult time in life with better recognition of their needs and wishes and ensuring that those needs and wishes are honored. Not only does it improve the experience for those involved, but it drives down waste and cost. And WAHA is facilitating the North Sound Accountable Community of Health that Aaron mentioned. It's a state initiative to create accountability at a regional level. It has the potential to address the need for community engagement, transparency, and accountability, yet to be seen, for sure. So what needs further work? Well, let me start by what I heard from all of the people working on this issue in the community. Primary care capacity, and primary care capacity. A problem that existed before the Affordable Care Act and is even more critical now. There is also a need for a commitment to the desperately needed resources to implement a continuum of mental health and substance abuse services that are integrated into our medical system of care. We need whole person health, and we won't have it until we do that. As one local provider mentioned recently, the body from the neck up matters, just as much as the heart, the lungs, and the limbs. So in that neck-up spirit, adult dental health is still a challenge as well. But a primary concern to all the partners, and I think Aaron spoke to this in his remarks, is that we don't really have the cost and waste issues comprehensively addressed. The financial alignment isn't there, and there isn't a mechanism to capture the savings and reinvest those savings outside the medical system and improve health. So where do we go from here? Well, first we continue to advocate and support for sound health policy, like we've always done. But as was mentioned earlier, we have to recognize that policy and legislation, like the Affordable Care Act, is a vehicle for change. It puts change in motion. But the political process rarely advances or sustains that change. And that's where we come in. It's communities that do that work. They rely on the partnership between the private and public sector, and they are really committed to making things work better for the people in their communities. As a community, we need to continue to work on transforming the healthcare system, and we are really well equipped and positioned to do that. We are so fortunate to have the organizations and the partners committed to this work. The Whatcom Alliance, the Health Department, Peace Health, Family Care Network, Interfaith Family Health Center, CMAR, the Opportunity Council, Planned Parenthood, the list goes on and on. They're working on this every single day. But we need to stay focused on the for sake of what? Which is improved individual and community health. So what does that mean? As was mentioned, the medical system really plays a relatively small role in improving population health. Our public health systems knows that the social determinants of health are what are the best indicators of population health. That's adequate housing, children ready for school, and educational opportunities for all. Families living with living wage jobs, access to healthy food, recreation, and community connections, access to preventive and primary care health services when they are needed and where they are needed, and the absence of mental health, substance abuse, and domestic violence. So the transition from transforming healthcare to community health improvement is vital. 4 years ago, the Whatcom County Health Department and Peace Health co-funded a community health assessment. It identified that overall we're a healthy community, but disparities exist among the averages related to economics, education, race, ethnicity, and geography. Here's a couple of facts. 16% of Whatcom County children and 67% of single mothers with young children live in poverty. We have a higher rate of child abuse and neglect than the state average, and high school graduation rates vary significantly by race and ethnic groups. Those findings have informed a 2-year discussion about the opportunities for improving community health that's captured in the Community Health Improvement Plan, or CHIP, which is committed to improving health, reducing disparities, and advancing equity through 3 major initiatives. And I encourage you to look at this plan on the Whatcom County Health Department website. There's 3 strategies: improving child and family well-being, with a focus on making sure all children get a healthy and even start. A focus on healthy living, recognizing that place matters when it comes to nutrition, activity, and connectedness. And whole person care, where we ensure that all people had the medical, behavioral, and dental health services they need. This is only possible with a culture of community voice, engagement, and accountability, so that we respond collectively to these challenges with the understanding, the resources, and the collective will. So let's connect the dots between transforming healthcare and improving individual and community health. As a funder, and with my funding colleagues like the Whatcom Community Foundation and United Way, we're ready, and our community partners are ready, and many community voices are ready. So let's embrace and act on that possibility. Thank you very much.
Thank you, Sue. Well, now comes the time in our program when our badge-wearing members can ask questions. But we'll have 2 people, one on either side of the room, to take your questions, and our speakers will get a chance to respond. If you put your question to one speaker, the others will have a chance to respond, and then back and forth to one another. So Chuck is over on this side, Victoria on the other side of the room. So we start.
Just one question. What does network adequacy mean?
That is a really good question.
What does network adequacy mean? What it means is that you have enough of the providers in your network so that you can live up to the promises you've made in the health insurance policy that has been bought by a consumer. Failure to have adequate number of doctors and hospitals and clinics means that you're selling an illusory benefit because you'll pay your premiums, but you'll play havoc trying to find a provider that will accept it. So we want to make sure that you meet a minimum standard. If you want to market a plan, you've got to make sure that you have an adequate number of providers geographically spread around the area that you're attempting to service.
Could you speak to the issue of business enrollment in the Affordable Care Act, please?
Business enrollment is one where you wind up with small business being able to receive tax credits by virtue of going through the exchange and receiving the credits. There are some opportunities outside of the exchange that have been extended in these early couple of years, but in the end, it's really one of wanting to see strength in the small group market offered through the exchange. And again, nationally, it hasn't taken off the way it was anticipated that it would. And in this state in particular, where we're challenged, we have 3 carriers that will be for 2016, United, MODA, and the third one I'm drawing a blank on right now. But we have 3 health insurers that will be offering in the small group market.
Kaiser?
Kaiser does do it, that's
Down
right,
in Clark.
and for 2 counties, that's right. And so what needs to happen is we've got to make sure that the companies that do offer outside the exchange in the small group market will be incentivized to come inside the exchange and not feel that they'll be penalized. And the reason they'd feel they were penalized is that the good risk is tied up with associations, and they're fearful if they come in, they'll only attract the bad risk because the others will stay with the association health plan business. That's why I'm working and taking some body blows for it to try to level a playing field here to make sure that if you are an association offering plans, you've got to play by insurance company rules. You've got to make sure that if you have a member in one location and another one who is identical in another location, that they pay the same rates. And there's some real resistance to giving me the information to make sure we make that decision. But if you don't do it, you wind up bifurcating the market, and that's limited competition in the small group market inside the exchange in the state of Washington.
So there's another aspect. So that Commissioner Kreidler was talking about the small group market, and what's important to know is that in the Affordable Care Act, small employers with fewer than 50 employees are actually exempt from a mandate that they provide coverage. So the SHOP, the small business market, is meant to give them an inducement, an easier way to enroll their employees. For larger businesses, the law basically says you're required to provide coverage. There's some exceptions and complexities to that, but you're required to provide coverage. If you don't, and one of your employees goes to the exchange and gets coverage that's subsidized, the employer of that person is liable for a penalty. And this is going to be, I mean, I think it's this year is the first year that mandate has kicked in. The administration had delayed it a couple of years. So we don't know exactly what effect it's going to have. We have seen some of the larger employers like Walmart change some of their policies, I think, to try to not be liable financially as much. But I think how that mandate plays out, I think, remains to be seen.
Okay, raise your hand, please, because it's hard to see. So, okay, over here.
You've talked about how the ACA has increased the number of people who have insurance. You've also talked about the fact that there's been a significant growth in high deductible policies, which many of us, I think, have witnessed. I would like you to comment, please, on the consequence of that. I witness many families that I've talked to where the deductible is so high, they are discouraged from going to the doctor for primary health care. They're looking at a $250 bill because they're so far away from real insurance. And we have a gap then between having health insurance and having access to health care. Can you comment on that, please, and how that could be improved? Thank you.
Start.
Sure. Go ahead. You first.
No, you go ahead. I'm dying to hear what you have to say.
One of the things that the general public does not necessarily readily identify with, yes, they do have those out-of-pocket with the copays and the deductibles, and particularly if they went with one of the lower tiered plans like bronze. I almost wish they'd ban the bronze plans because there is so much out-of-pocket expenses associated with those plans. Lower premiums, but you pay the price when you access any kind of care. I would like to remind everybody that one of the things that's part of the Affordable Care Act is a limitation on out-of-pocket expenses. So once you reach a certain percentage of your income, you have the opportunity to be free of copays and deductibles because of the amount of money that you're paying out. That limitation in overall spending is a huge protection. The downside has been that we see these increases in copays and deductibles until you reach that threshold. Or if you don't reach it, then you have significant more being paid out. I think the real choice for consumers is going to be a great deal more transparency in the shopping experience, where it's easier to take a look at the copays and deductibles in a meaningful way for you as an individual. It kind of reminds me of back when we went to having competitions for long-distance carriers with our telephones. It's still kind of the Wild West out there, and then it's going to start to stabilize as it did for long-distance carriers. We're going to see the same thing happening here in healthcare. Better information, better understanding of the pros and cons of a particular health plan over another one. Not necessarily the cheapest plan, but you'll have a much better idea of what is provided in the drug formulary to the network of providers and the kind of out-of-pocket expenses that you'll see with a particular plan. Once more, it's asking people to become shoppers because it's possible to do shopping. Without healthcare reform, it wasn't even possible to do that.
I think one of the things, though, that you mentioned that's really important and is the reality is that it's really important for people to have coverage, but it doesn't necessarily translate into access. And I think that's the issue that we really have to face right now. And there's a number of barriers. One is this copay deductible maximum out-of-pocket issue, which is a significant barrier for low-income families, which tend to access those plans and have the least capacity to pay for services. The other is just the capacity of the system isn't lined up properly yet to handle all these people that have coverage. And the third issue is that even if you do have deductibles and copays, it's very difficult to understand what the cost of care is going to be if you actually need care. And until consumers have the ability to look at charges, what they're going to be charged for care, not just what their insurance company's going to pay, they aren't really in a position to make the choices that they need to be making. So this issue of transparency and having access to that information is really, really critical, and it's not an easy thing to do. So all of those elements need to come into play for in the next, how many years, 30 years, 40 years, to make this all work.
Well, so I think maybe we found a point where we might have a little heat on the panel.
It's supposed to be light. It's not
light, okay, some strobe lights on the panel. So I'm not as sanguine as Commissioner Kreidler is about the out-of-pocket issue. I think, while yes, for some people, the limit on out-of-pocket spending is going to be a benefit, the insidious effect of high deductibles, and we're not talking about the highest deductible plans, but plans that might have a deductible of $2,000, which is sort of mid-range now, is that people, as you suggested, are making decisions not to seek care because of that out-of-pocket cost. And what we know from very good research going back to the 1970s and repeated many times since then is that people are very bad at determining which services to avoid because it's not going to be worth the $50 and which services that will be worth the $50. basically people avoid both beneficial and non-beneficial services. And of course, you can, it doesn't take much to imagine the effect, what happens when people avoid going to a primary care doctor because they have a fever or their kid has a fever. That's the more prevalent and more insidious effect of having high deductible policies out there that are actually very frequent. A lot of the policies that have been bought, even the silver plans, are relatively high deductible. We're asking people, the model here, the reason we have high deductible plans is this notion that if people have, quote, skin in the game, if they have to pay out of pocket, they'll make economically wise choices. And just like in other markets for cars or washing machines or food, those economically wise decisions will make the healthcare system more efficient. Well, people when they're sick, or their kid is sick, or their parents are sick, are not going to make economically wise decisions any more, than we are if we're hungry, going to the grocery store and making smart, decisions about food. It's a bad time to go to the store when you're hungry. I think the model, this economic model, that part of the Affordable Care Act is based on is fundamentally flawed. And I think the point you made in the question just reveals that flaw. I think we're expecting people to be price sensitive at times when they won't be and they can't be.
I would tend to agree with you from the standpoint of, I think this is another.
Want me to sit in the middle?
Yeah, this is another case where having a dysfunctional Congress right now to address some of these issues, such as what we're describing here with the co-pays and there are places where it is clearly has an adverse impact on the health of the community when you have the people not accessing the system when they should be accessing and getting the kind of treatment and care and early detection that is critical to them. But again, I think it's one where with another Congress, we'll start to see that as being very much in the best interests of overall society, and we're going to move toward enhancing the kind of funding. But in the current environment, I don't look for those kind of solutions to be coming forward. So we will stumble over this, but it's so much better than what we had before.
Okay, great. Here.
My question is, I'm not sure to which one of you, but for those of us that have kids in college, we've found, particularly with our family, that if they go to college in another state, it's very difficult for them to get coverage. Is there anything being done about this kind of loophole with portability in our young people?
Yeah, and that's a problem. So, if your child is going to school in a state that didn't expand Medicaid and is using the federal exchange, that's a problem. I mean, I know that universities have, because of the Affordable Care Act, universities in this state have moved away from student coverage because, number one, students up to age 26 can be on their parents' plans, and afterwards, well, they can go to the exchange. But your point is that if your kid is under 26 and is in another state, it doesn't really help that that child is on your plan because none of the providers, in that other state are, unless they're Blue Cross Blue Shield has a national network, et cetera. So I'm not sure that there's a ready-made answer for that.
I don't think there is. I think that's one of the, again, it would be part of the shopping experience, assuming that you have the ability to make your own decisions and it's not tied to an employer making the decisions for you, to find out which plan out there offers the best service where your child is going to be residing and potentially picking a different plan for yourself, if for no other reason, is so your child would have access to coverage while they were in another state where it wasn't as friendly an environment as we have in the state of Washington.
I'd like to buy a platinum plan in Whatcom County, and it's not offered. So I'd like to know why insurers are allowed to offer all 4 plans in some counties and not here.
It really is a decision on the part of the insurer as to which counties they're going to offer their plans. They're not locked in and having to offer it in all. And I don't remember just right offhand which counties have platinum plan opportunities. In the first year, 2014, I don't believe we had a single platinum plan being offered any place in the country. For 2016, we have some that have entered the market with platinum plans. Again, that means that you pay a lot more for the premium, but you have less out-of-pocket expenses associated with it. I would anticipate, given the trend we've seen here with more insurers coming in, the broadening out of the number of plans that are offered by each of those carriers, that if not in 16, in 17, it's very likely you'll see it here.
A question here, Don?
Well, I'm actually trying to formulate this. I realize that we're talking insurance, and insurance companies come up with some sort of deal with hospitals or whatever. But the question about access and charges and whether you know what your charge is going to be ahead of time also relates to hospitals and charge master fees that seem to have no reality to them at all. They're not based in reality. So I'd like to know who has any control over that? How can that be addressed?
Well, we have some challenges there. One of the issues that we're looking at right now through my office is what happens to you when you do go to a hospital that's in network, and you do have the surgeon that is going to provide the surgical services is in network, but what happens when they bring in an anesthesiologist or somebody to do assist who's outside, and therefore you're of the network, and therefore you're effectively paying billed charges? That becomes seriously problematic, and that's something we're working on. It's a loophole I want to see closed so consumers don't receive surprise billings that come in after a medical procedure when they assumed it was all done the right way when in fact it isn't. So we've got some challenges in that regard.
You want to talk about the all-payer database?
Well, just about in terms of hospitals, how can that be affected in terms of hospital charge master fees?
Don, Larry, I'm just wondering, do you see any opportunity in the accountable community of health work to address the issue of pricing?
I think the issue of hospital charges versus what is actually paid by payers is so entrenched that it's not likely to get changed.
Aaron reminded me of what was an important issue. This last legislative is already signed into law. It's an all-payer database. This is really a combination of business and providers and consumers all coming together to develop what will be an all-payer database, meaning all claims data, not kept secret any longer, because you never know what your health insurance plan has negotiated as the price for a particular hospital-based service. And it's not the same from one insurer to another. But that information now is going to be public, and I think that's going to bring in a whole new air of competition so that you get away from this gaming. One of the things that's really always bothered me is that you could wind up with a small health plan that wanted to enter the Washington market and establish itself, not being able to negotiate rates even close to the same as a large insurer that really had the provider over the barrel. So they got the best price, and then the new plan coming in would offer competition, has to pay a premium for that. Now, with an all-payer database, it's going to be transparent.
Okay, we're at the end of our time, but I would like to ask our three panelists to get out their magic wands, and if there was something they could do to improve health care, in 30 seconds, what would you do? So that we will be healthier communities.
I'm going to sweep on
Healthier
this one.
communities.
Yeah. What would you do?
Okay. You're going to sweep on this one?
Mm-hmm.
Okay, I'll throw the dirt down so you can sweep it.
Yeah. This is the spectrum of cynicism and hope.
I would quadruple our investment in K through 12 and higher education. And take it all out of the medical care system.
I think that from my standpoint of what I would see, looking more incrementally as to kind of the changes we can make in the system, Sue touched on it, and that's certainly having the adult dental option available inside the exchange plan would be a major step forward. You can do it in the outside market right now, which is as large as what we have in the enrollment inside the exchange. Out there, they have an adult wraparound. Inside the exchange, they don't, and that needs to change because it becomes a strong inducement for, particularly for parents with children, if they have to have the pediatric benefit inside the exchange, but if you don't have the adult, you're much less likely to get the kids in there getting that early treatment and care at an early age. So if I picked one thing, it's expanding the adult dental into the exchange.
Well, I think that I'm committed to transforming the healthcare system so it's better, so that we create savings that are invested in education and early childhood services. That's probably the most important investment that we can make.
Thank you to our speakers. Let's give them a big round of applause.